Welcome to Talking Type 1 Diabetes, a podcast series for healthcare providers who manage or treat type 1 diabetes, or those who just want to learn more about this life-changing progressive disease. Each episode features conversations between leading experts in the fields of endocrinology, primary care, and diabetes care. This podcast episode reviews the pathophysiology of type 1 diabetes as an autoimmune disease and the role of beta cells in glucose homeostasis. You will hear from Dr. Teresa Quattrin, co-director of Community and Stakeholder Engagement at the University at Buffalo Clinical and Translational Science Institute in Buffalo, New York. Dr. Quattrin also serves as Associate Dean for Research Integration at the UB Jacobs School of Medicine and Medical Sciences, where she is a distinguished professor in the Department of Pediatrics, and Dr. Kupper Wintergerst, the Chief of the Division of Endocrinology, Department of Pediatrics at the University of Louisville School of Medicine in Louisville, Kentucky. At this institution, Dr. Wintergerst also serves as Wendy L. Novak Endowed Chair of Pediatric Diabetes Care and Clinical Research, Director of the Wendy L. Novak Diabetes Center, and Professor of Pediatrics in the Division of Endocrinology. Dr. Quattrin and Dr. Wintergerst are being compensated by Sanofi for this podcast episode. TZIELD is a CD3-directed antibody indicated to delay the onset of stage 3 type 1 diabetes, T1D, in adults and pediatric patients aged 8 years and older with stage 2 T1D. Please see important safety information on screen and additional important safety information and full prescribing information provided at the end of this episode. Let's begin by hearing our experts discuss the fundamental role of beta cells in glucose homeostasis and how this is disrupted in T1D.
One of the things that is the most surprising to the people that we meet, families and individuals that are not familiar with the fact that there are many, many forms of diabetes, that type 1 diabetes is so distinct. And having experience, managing children and adults with type 1 diabetes, we realize that it's a condition that spans our entire lives, right? So it's everyone, no matter how old they are at risk. And when we think about diabetes, I think one of the things that at least I start out with, I think we both start out with when we're talking with families is first of all, what's the importance of blood sugar, in our bodies? And so kind of going down to the basics so they understand what's the importance of insulin, why do our bodies need it? And I like to talk about things at the most very basic, so energy. A lot of kids and adults understand the concept of energy. They stay up too late playing video games at night. They wake up after 3 hours of sleep, they're exhausted. And so they match up with that concept pretty well. And so glucose or blood sugar in the body is one of our primary sources of fuel, and the beta cells in the pancreas, really the primary responsibilities of the beta cell is to read or register the amount of glucose that is in the system, and with that measure, that sort of measuring stick determines how much insulin is going to be produced and then released from the beta cell. And that process occurs continuously, every single second of our entire lives. And as the glucose goes up or goes down, then the beta cells respond in mass throughout the whole pancreas to produce insulin or decrease the amount of insulin that's being produced. And so, when we like to talk about energy production, we talk about the fact that insulin is needed for that glucose to move into the cells of our body, so our brain cells or our heart cells, muscle cells, bone cells, and so on. And that, along with the oxygen that we breathe every day, every second of our lives, is utilized to make energy for our cells and our organs and our whole system. And so I think the describing that, all of a sudden there's a light bulb that goes off in our patients' heads that, oh, so that's why we breathe. That's why blood sugar and insulin is so very important.
Yeah, and you know, I like to tell patients that insulin is almost like a key that allows for glucose to be utilized. The beta cells has glucose transporters, and as you pointed out, usually following a meal, there is a glucose increase, and then the beta cells glucose transporters will uptake the glucose and then produce insulin that will be then used to be able to create energy. And I like to explain to our patients that insulin is like a key allowing for all of this to happen. So without that key, unfortunately, protein and carbohydrates cannot be used by the body. And therefore, that explains why people who have a very poor insulin reservoir will lose weight, because despite the fact that they are trying to eat a lot, nutrients don't get used. What's amazing about the beta cell is this wonderful dynamic process that you described, so that the beta cell will respond to increases in blood sugar, but will also be so perfect when blood sugar is lower, such as in fasting states or when we're physically active. So it's a perfect dynamic system that allows the person to produce insulin when needed and shut it off when it's not needed. Unfortunately, this system gets all disrupted when the beta cell gets attacked by the autoimmune process and gets destroyed. And that creates a progressive problem where progressively many beta cells are not functional, and that leads to lack of insulin, and the person eventually will be dependent on exogenous insulin. If they do not have that, they cannot survive. So it's a perfect system, and the damage of this perfect system leads to irreversible and dramatic consequences.
Absolutely. I mean, one of the things that I was curious to know from your perspective is how you describe to patients, families, and actually other clinicians the what happens to the system when you're not able to. So you either don't have sufficient amounts of glucose available, or you are unable to use glucose as your primary fuel substrate because you don't have you're not getting enough insulin. So in the form of ketones and so on. I was wondering how do you describe that to your patients?
Yeah, I try to explain the concept that we've talked about, insulin being a key, and the fact that in our meals we have carbohydrates and protein, and without insulin we cannot use those. However, our body has fat, and when insulin is actually decreasing, the body doesn't have the energy coming in from protein and carbohydrates, and so will actually rely upon stored energy in the form of fat. And when fat breaks down, that is when the ketones are produced. And ketones, we look at ketones as, in lay terms, as a form of acid that builds up in the body. And so when patients are close to insulin dependency, not only they spill glucose in the urine because the sugar goes too high in the blood and cannot be reabsorbed, but they also will spill these ketones in the urines, and there are ketones in the body. And importantly, this accumulation of acids, including the ketones, are responsible, unfortunately, for a state of severe illness called diabetes ketoacidosis, which unfortunately Kupper and I still see quite frequently at the diagnosis of the stage 3 of type 1 diabetes, which is insulin dependency. And it's the person is very sick.
Yes.
Often we are called to the pediatric intensive care units or the intensive care units for adults because the patients are so sick that they need very close monitoring to be brought out of a critical state that can lead to their demise.
And you pointed out perfectly the threat really of the lack of what happens with the lack of insulin, particularly in someone with diabetes, where there is sufficient glucose in the system, right? Because they aren't fuel deficient because they've been starving. They're literally starving only in the sense that their cells are not getting fueled properly, and so in most cases, the diabetic ketoacidosis, the patient is hyperglycemic, so high glucose values. They are often, in most cases, dehydrated in some fashion, often moderately or even severely dehydrated because they've been urinating, demonstrating those key signs and symptoms that we learn about in medical school and that we try so hard to express to patients, families, school teachers, physicians in our community, people to be aware that that polyuria, polydipsia, polyphagia, that weight loss, all of those things are signs that the kidneys are not able to reabsorb glucose and the patient is getting more dehydrated. And I think the thing that is most frustrating in my career is working so hard at that advocacy, but because DKA looks so much like illnesses that we pediatricians and internists and family doctors and ER physicians, ED physicians see every day with vomiting, nausea, vomiting, body aches, etc., that it often gets missed. And if we could do, if I had a choice of one thing that would turn the tide for how we approach diabetes, it would be that early detection, is discovering or identifying those signs and symptoms of diabetes so much earlier, so that DKA, doesn't happen. And before, I think it would be valuable to share a little bit more about the pathogenesis. But I was wondering, from your perspective, how often in your population do you see patients that end up in the emergency department and then the ICU when they could have been picked up earlier and ended up in your office to more easily manage for those first time period with diabetes?
Unfortunately, Kupper, it is still very very frequent. I would say it's probably here in Buffalo at least 50%. But when you look at national statistics, are really higher than that. And as you pointed out, the only way, as we will discuss in further down in our podcast, the only way to really figure out that somebody is at risk is to check these markers. And that people have way ahead of the time when they have symptoms. And this is especially true because the majority of people who have type 1 diabetes don't have a family history. And so it becomes like almost stabbing in the back. How is that possible? Right. We don't have anybody in our family. And it's really hard, as you pointed out. How do you how do you explain things to people? What happened there? And the very first thing that I do tell them is try to dispel myths. So things that, I did something wrong during my pregnancy because I was eating too much sugar,
right.
or I introduced this or that too early. And I try to explain that it's a combination of genetic makeup, trying to explain that the genetic makeup, it's not the classic things from father to son or mother to son, but rather the way the genetic system that controls our immune system is made and predisposes in some individuals, coupled with environmental issues, including viruses. And I explained to them that following this milieu, the beta cells ordinarily contains, the islet cells contains beta cells, but also other cells like the T cells, which normally are good cells in the body because they help us defending ourselves from infections and things that come from outside our body. But unfortunately, in type 1 diabetes, the autoantigens activate autoreactive T cells, and it's almost like an overwhelming state of inflammation that ultimately leads to production of autoantibodies and the demise of the beta cell.
Thank you for your insights. Now, let's discuss the importance of identifying the early stages of type 1 diabetes.
So we know that it's a multifactorial health condition that ultimately activates this process. Many of the patients, as you said, have some type of genetic risk. So if you have a family member with type 1 diabetes, likely you carry those genes, those HLM, so basically genes that increase your risk compared to the general population. Although, of my patient population, so we have been doing TrialNet for many years, and we have screened hundreds and hundreds and hundreds of families, and of those, we do pick up, we are able to identify those patients early because they have antibody testing through TrialNet that's free of charge, which is wonderful. If they're positive, then there's a process by which we can monitor them with glucose testing. And when we have picked them up, the experience is so much different than our family's experience when they present DKA. The reality is that there's this understanding that a family member might increase your risk of a health condition, and I think that's a very well understood concept in our world, in our communities, that if my dad had heart disease, I'm probably at a higher risk of heart disease or high cholesterol, or my grandmother had arthritis. So in your head, you're thinking, okay, I might be more at risk for arthritis. And so we have many of our families that choose to get screened who have that risk. And when we pick them up, their journey through this experience with type 1 diabetes is it's a stressful and emotional issue when you find out that you're positive. But when we catch them that early, they're able to come to grips with it. We're able to work through a plan, work through this process of monitoring over time. And in the past, 10 years ago, we would help to ease them into it, and they would start low-dose insulin. Most of them would change their diet in some fashion. They would try to, as a family, become a healthier family unit, and it actually did. Again, it was a more healthy, positive experience for them. And then you switch that to some of the things that you and I have been describing, that the DKA, which I think deserves us to keep reinforcing it every chance we get. I'm looking back in time over just the last 10 years. I had a patient who The mother has had type 1 diabetes. She still does, and her son, she figured he was at a higher risk because she has type 1 diabetes. And at the time, she just thought he was becoming more ill. She took him to her pediatrician's office. They thought it was a flu-like illness, gastroenteritis, and recommended supportive care. And the family just didn't continue to watch how quickly he was declining. And by the time he reached the emergency department, he was very ill and ended up in the ICU. And he ended up having to go through multiple surgical procedures just to try to preserve his life. He ended up on a ventilator and ultimately passed away. And so that wasn't 25 years ago. That was less than 10 years ago. And so what it tells me is that even when you have a family who is aware that diabetes can happen, when you don't know that your child has those antibodies and he or she will definitely eventually need insulin, you sort of turn to the other more common things. Common things are common. And so what struck that family to the core was that diabetes wasn't preventable for him, but that he would still be alive had we been able to identify his diabetes earlier, right?
Definitely.
And so I think that's one of the drivers for me in talking so much with anyone I can that will lend me their ear about type 1 is that you can simply doing that antibody testing and identifying it can pick that up early enough that you can change their life.
Yeah, and we have ways in educating the public, making them aware that type 1 diabetes can occur anytime, even in senior citizens. And it's important to check for these autoantibodies, because without that, you don't know if you're facing the autoimmune process, which is classic of type 1 diabetes, or another kind of diabetes. And one other point I do want to make about DKA, as you pointed out, we have unfortunately all lost patients to DKA. And not that long ago, as you pointed out. But what's important is to remind ourselves that being diagnosed with stage 3 and insulin dependency when you are in acidosis and very sick not only carries the immediate critical consequences of being very sick, but it has consequences afterwards in terms of more difficult metabolic control and in turn preventing diabetes complications. And I don't think I think that sometimes we overlook that point, and it's really, really critical that we keep that in mind.
There is a lot of data looking at all inflammatory health conditions and the impact of chronic inflammation on the human body, whether it be the pancreas or the heart or other organ systems. And the reality is that if we can intervene early by altering that progression, that inflammatory progression, we may delay and become healthier people.
Thank you, Dr. Quattrin and Dr. Wintergerst, for explaining the pathophysiology of type 1 diabetes, the crucial role of beta cells in glucose regulation, and how to optimize patient care to reduce risk of DKA and associated complications. Your expertise will equip our audience with a deeper understanding of the disease mechanisms, allowing them to better support and manage their patients with type 1 diabetes. Thank you for listening to Talking Type 1 Diabetes, a podcast series for healthcare providers who manage or treat type 1 diabetes. Be on the lookout for other episodes of the Talking T1D podcast, available on TZIELD-HCP.com and YouTube. For more information regarding TZIELD, visit our website at TZIELD-HCP.com. Please be aware of the TZIELD indication and important safety information, indication and usage. TZIELD is a CD3-directed antibody indicated to delay the onset of stage 3 type 1 diabetes in adults and pediatric patients aged 8 years and older with stage 2 type 1 diabetes. Warnings and precautions. Cytokine Release Syndrome, or CRS. CRS occurred in TZIELD-treated patients during the treatment period and through 28 days after the last drug administration. Prior to TZIELD treatment, premedicate with antipyretics, antihistamines, and/or antiemetics, and treat similarly if symptoms occur during treatment. If severe CRS develops, consider pausing dosing for 1 to 2 days and administering the remaining doses to complete the full 14-day course on consecutive days. Or discontinue treatment. Monitor liver enzymes during treatment. Discontinue TZIELD treatment in patients who develop elevated alanine aminotransferase or aspartate aminotransferase more than 5 times the upper limit of normal, or ULN, or bilirubin more than 3 times ULN. Serious infections. Use of TZIELD is not recommended in patients with active serious infection or chronic infection other than localized skin infections. Monitor patients for signs and symptoms of infection during and after TZIELD administration. If serious infection develops, treat appropriately and discontinue TZIELD. Lymphopenia. Lymphopenia occurred in most TZIELD-treated patients. For most patients, lymphocyte levels began to recover after the 5th day of treatment and returned to pre-treatment values within 2 weeks after treatment completion and without dose interruption. Monitor white blood cell counts during the treatment period. If prolonged severe lymphopenia develops, less than 500 cells per microliter lasting 1 week or longer, discontinue TZIELD. Hypersensitivity reactions. Acute hypersensitivity reactions including serum sickness, angioedema, urticaria, rash, vomiting, and bronchospasm occurred in TZIELD-treated patients. If severe hypersensitivity reactions occur, discontinue TZIELD and treat promptly. Vaccinations. The safety of immunization with live attenuated live vaccines with TZIELD-treated patients has not been studied. TZIELD may interfere with immune response to vaccination and decrease vaccine efficacy. Administer all age-appropriate vaccinations prior to starting TZIELD. Administer live vaccines at least 8 weeks prior to treatment. Live vaccines are not recommended during treatment or up to 52 weeks after treatment. Administer inactivated, killed vaccines or mRNA vaccines at least 2 weeks prior to treatment. Inactivated vaccines are not recommended during treatment or 6 weeks after completion of treatment. Adverse reactions. Most common adverse reactions, more than 10%, were lymphopenia, rash, leukopenia, and headache. Use in specific populations. Pregnancy may cause fetal harm. Lactation. A lactating woman may consider pumping and discarding breast milk during and for 20 days after TZIELD administration.